Hi, this presentation is on personality disorders. It's a big topic, a huge area. And as you know, for the class, it's a 2-week chapter. It's strange. This is the first time I've put this course online. And it's challenging because I like talking about these in discussion more than almost any of the other disorders that we talk about in this class. Primarily because when it comes to personality disorders, they're rather different from the other disorders. Most of the disorders that we've been talking about, as you recall, even with mood disorders, if you meet these number of criteria, then yes, you qualify for a major depressive episode. With personality disorders, we're talking about personality traits that we all share, that we all have. And some of those traits get extreme and really maladaptive in some people. So a lot of people argue, psychiatrists, psychologists, and others, that it should not be on a categorical system like major depression, where you meet these criteria and you have major depressive episode. Instead, you can think about a lot of personality characteristics existing on a scale of 1 to 10. So some of these, even personality disorders we're talking about, they've talked about scaling these, and you can consider that probably even most adolescents would be higher in traits like narcissism, which is this pre-absorption with a self, this just really self-absorbed, or even histrionic, which is very dramatic, or they can kind of call drama queens. It's different from some of the things we've been talking about so far. In the DSM-4, the old categorization system that's used by our textbook, they were placed in an entirely different section of that entire catalog system. In the current DSM-5, they are now considered to be just on par with all of the other disorders we've talked about so far this semester in this class. So as you know, personality by itself is just who we are, and by their nature, they're part determined by our upbringing and by what we're born with, our genes and our temperaments. We all have flexibility in learning, but when it comes to having a personality disorder, we're talking about very rigid, inflexible styles of interacting with other people, and they last a long time. So for most people, when they're going through adolescence and they have some of these traits which may be developmentally appropriate, for people who go beyond adolescence and continue to be narcissistic, histrionic, antisocial, things like that, that's when we start to categorize these as personality disorders. So personality disorders by their nature are maladaptive and inflexible. This is just not changing. And they revolve around one's own sense of identity, and also with that person and how they interact with others. Personality disorders are by nature really brought into relief or seen more clearly when you look at a person's relationships with others, whether they be work relationships, school, classmates, family relations. That's where you see these other people notice these so much more than some of the other disorders we've talked about. These personality disorders are usually recognized in early adolescence. They are notoriously difficult to diagnose because of overlapping characteristics of some of these. So it's estimated that anywhere between 4% of the US population to 14% of the population may have a personality disorder, which I've abbreviated through these slides as PD. Most of those folks who get diagnosed with one personality disorder will be diagnosable with another. On this slide, you'll see the DSM criteria for a personality disorder. These are on your Canvas notes, so I will not linger here. When I talk about the different personality disorders, there's 10 of them. We often try to map those out on personality traits or characteristics that are common to most people. And probably one of the biggest personality theories, if you've had that class here at Lincoln University, personality theories, you may be familiar with, called the Big Five. And it's abbreviated with the acronym OCEAN, OCEAN. And that stands for characteristics that you see around the globe. Openness is just having a willingness to try new things and learn about new things, an interest in novelty, trying to just be curious about the world around you. Some people are high in that, some people are low. Conscientiousness, you already know what that's about. Someone who's highly conscientious is going to be very detail oriented and try to make sure that they follow up on everything that they've said that they would do. People who are low on this are rather lax and slack and often don't care about whether they follow up on their word or not. Extroversion and introversion are different styles of interacting with others. Those who are introverted are fine and happy being alone. People who are extroverted really need more social stimulation, are frequently seen as more social. Agreeableness is how much you just go along with what's dealt you. If you are like, okay, I'll do that. Okay, I'll do that. That's being pretty agreeable. People who are not agreeable resist anybody trying to impose or to ask them to do something. Most of the personality disorders are low on agreeableness in general. Neuroticism is the final trait, and this is about primarily hostility and anxiety. And again, most of the personality disorders have high levels of neuroticism throughout. I'll refer to these big five frequently. Here's a map of a whole host of different personality variables that are associated with the 10 different personality disorders. As you can see, the ones in swamp green color that's the central feature of those particular disorders. The purple then are noticeable features among these personality disorders. And if they're white, that's not part of that disorder. There are 3 clusters of these different personality disorders. They're called cluster A, B, and C in this order. The odd and eccentric are A, and you see these different personality disorders there. Cluster B is considered to be dramatic, irrational, and emotional. And you see these personality disorders there. And then we have the last category, C, cluster C, anxious and fearful. I'm going to introduce A and C first, because there's a little less research on those and a little less to say about some of the interpersonal interactions. And I'll reserve the last part, cluster B, for the last part of this presentation. So cluster A, the odd personality disorders. They include paranoid personality disorder, schizoid personality disorder, and schizotypal. People with these disorders usually have behaviors that are often seen as somewhat similar to, but not as extensive as symptoms that you might see in schizophrenia. Some of the behaviors include being really suspicious of people you work with or you're around, withdrawing from others for a number of reasons, depending on which disorder we're talking about, and really odd, peculiar ways of seeing the world. A lot of those behaviors leave a person being socially isolated and withdrawn and not having opportunity to interact with others. Some people call this whole cluster schizophrenic spectrum disorders because they feel like that they're related to schizophrenia. Few in this cluster seek treatment, and not a whole lot is known. That's why, again, this is a briefer section on this particular cluster. The first personality disorder in cluster A is paranoid personality disorder. And this is one, again, I wish we were talking in person, because everyone knows someone who seems to be suspicious of other people's motivations all the time. They're constantly curious about, not curious, they're more worried. Someone's trying to get them. Someone's out to get them. Someone's trying to undermine them. Someone said something on purpose to hurt their feelings. So it is a constant scanning the environment, really, for looking for slights and criticisms, and again, any way to undermine what their goals are. Now, it is not like paranoid schizophrenia in that with paranoid schizophrenia, you have full-blown delusions. That is false beliefs that a person with paranoid schizophrenia might believe that the FBI or CIA is out to get them. In paranoid personality disorder, it's more like that person just said something. They were trying to insult me. They were trying to hurt my feelings. This is a different level of paranoid characteristics. People with paranoid see hostility in actions of others all the time, and they're very quick to anger. They're really difficult to get along with at work if you work with someone like this. You have about a half of 1% to 3% adults may have this, with men having it more frequently than women. Trying to understand where it comes from, it's primarily theoretical. Some psychologists say that parents warning too much to be aware of all the dangers kind of trains a child to become very suspicious of other people, or parents who are just really rigid and demanding and controlling that make everything outside the outside world seem threatening, perhaps. The second of the personality disorders in this cluster is called schizoid personality disorder. This is some people, as I put here, compare or think it's similar to autism, because you see a pattern of ignoring other people or being emotionally unresponsive to other people. It's possible, just again, consistent with schizophrenia, as we'll see when we approach that chapter, that dopamine and low levels of dopamine may be related to this style of basically not interacting with others. So they lack interest in social relationships. It's almost like they're observing the world and not participating in it. They don't express their feelings clearly. They're often seen as detached or cold. Also, they have a lack of ability to really experience pleasure in the way most of us like to. They don't really need approval. In treatment is recommended for this is that you try, if someone has concern, most people in this entire cluster never seek treatment. Someone with paranoid personality is scared the therapist is going to try to undermine them or is somehow trying to hurt them. People with schizoid personality disorder, they don't care. So one of the things that your book talks about is ego-dystonic or ego-syntonic symptoms of a personality disorder. When it's dystonic, a person has the symptoms and they don't want them. So if a person is depressed, they don't want to feel depressed. So that's ego-dystonic. With a lot of the personality disorders, the characteristics, personality traits, symptoms are often ego-syntonic, or they're the person who has these symptoms, they're okay with them. They find them acceptable. And so a person with schizoid personality disorder probably will not seek treatment. If they do, they often get training by the therapist about how to show social skills or use social skills. And most providers, therapists and counselors say that the outcome is usually pretty poor. The prognosis is poor. The third and final one from this cluster is called schizotypal personality disorder. This one may be most closely linked to schizophrenia, as I put down here in this part of the notes. In people with schizophrenia, if you ask them to track a moving target that kind of goes in a sine wave, you can see their eyes really following that. With a person with schizophrenia, their eyeballs go back and forth kind of erratically like that as they're trying to follow the target, similar to people with this particular disorder. People with this disorder also have memory problems. They have difficulty keeping their attention on a given target. They also have some brain similarities to people with schizophrenia with large ventricles. And they appear more like people with schizophrenia because they're eccentric in their dress. They may collect things and mumble to themselves. When I say ideas of reference, they may think that things on the TV are referring to them. So the reference referring, so they think that things that aren't related to them are actually referring to them, but they usually have better reality testing than a person with schizophrenia. They often think they have magical powers. I had a family member at one time that I was not biologically related to, who I think had this disorder, and he went around my hometown trying to sell magic wands to farmers. Said that if they use these magic wands on their livestock, it could heal them from all sorts of diseases. In retrospect, it appears they probably could have been diagnosed with schizotypal PD. They're often not very productive and lonely. Not clear what causes it. About 2 to 4% of the population may have this. That's still quite a bit. It's bigger than the number in schizophrenia. Therapy is regularly recommended to treat people to social skills again and how to accept themselves. Sometimes they use antipsychotic medications. So we're switching from cluster A to cluster C. As I mentioned, cluster B is the longer or the more extensive cluster of personality disorders. With anxious personality disorders and fearful is what this cluster is known for. You have three different types: avoidant, dependent, and obsessive compulsive. An avoidant personality disorder, basically a person sees themselves as inferior. You may remember when we talked about anxiety disorders and social phobia, people feared social circumstances. Here, social phobia, people with avoidant personality disorders see themselves as being just totally inferior. So it's more like social interactions in general. They fear social relationships and circumstances. They dread disapproval. And so it's a higher level of fear that's associated with social interactions that it could occur. They often live in fantasy connections with celebrities. Dr. Argetti, who is a faculty member in psychology at Lincoln, does research on celebrity worship and has been coming up with all sorts of data related to this. So if you have an opportunity, you may ask her about that research. Usually folks with this disorder are considered shy and hypersensitive to criticism. Men and women have this equally, and about 1% to 2% adults have this. There are some criteria that I won't read through, but they will be up on Canvas for you, so you may take a look at those. Causes of it may be harsh criticism in childhood growing up, that people learn to expect rejection and interpret any sort of communication in that way. Shame, some say bullying, some say it's biological, that basically the person's temperament is just from day one very shy and very reactive to their external environment. It's difficult because the clients need approval, but then they begin to doubt the sincerity of the counselor or the therapist. Once again, social skills are usually used in training in a therapy setting here. The second of the three disorders in cluster C is dependent personality disorder. And you get anxiety here because the person feels like they can't do things for themselves, so they're always looking for somebody else to do it for them. The two beliefs I have here are: I'm inadequate and unable to cope with the world, and I must find someone to take care of me and protect me. They depend on others to make the smallest decisions, to help do anything. I knew one person who could not, even though they were my age, could not put gasoline in their own car because they always expected their spouse to do it. A full-grown adult. They need reassurance all the time. I've had a coworker with this disorder as well, who could never do anything on their own computer and constantly went to other faculty, but finally found one faculty member who continually they leaned on to do all this work for them. And that faculty member eventually left. And consistent with dependent personality disorder, that faculty member found another person to help them with everything that they were trying to do. So if they are abandoned, they find somebody else to help them with all their things. They build their lives around others, and then they don't care who they end up with romantically, just as long as they're with somebody who will help take care of them. So they don't get angry at others because that would lead to a disruption of that dependence. They fear being left alone. They may rely heavily on the whole medical system. We're going to get to histrionic, but the people dependent are very self-deprecating. They just like, okay, oh, I can't do this. It's not me. And they don't have much of a personality. They're often bland. It's comorbid with depression, just like itself, and anxiety. They appear to go along with anything, but that's primarily because they don't want to lose someone who could help them do all the stuff that they need to do in life. Some say that probably the behavioral cause for this is being trained as a child that you can't do things. In one theory of personality, Alfred Adler talks about birth order, would probably argue that the last born child in a family of many children would be prone to this more than any, because last born children are surrounded by not only parents, but also older siblings who rush in, try to act like a parent, do things for the child, and give the child the message, you can't do this for yourself, you need help with everything. There's also authoritarian personality, authoritarian parenting style that is very directed, very demanding, very controlling, very cold, that some argue may be a factor in developing this personality style. I put it on here even in terms of learning theory. Sometimes it's argued that people with this disorder have been punished for trying to be independent and rewarded for being more dependent. Treatment involves be aware of dependent transference. That means as a therapist, be aware that if you have a client with this disorder, they're going to want to lean on you and have you do things for them. So being cautious of that and having your eye out for that's important. Training about how to be assertive is critical. Stating this is what I need to do for me. This is what I have to have done. Being very assertive in that way. Challenge belief of one's incompetence, and also the fear that if I'm insufficient, if I'm self-sufficient, I'll be alone. That's kind of an undergirding belief in this particular personality disorder. Antidepressants are sometimes helpful with this disorder too. The last personality disorder in this cluster, cluster C, is called obsessive compulsive personality disorder. It is different from obsessive compulsive disorder that we talked about in the anxiety disorders. In the anxiety disorders, we talked about OCD as being characterized by having obsessions and compulsions, the intrusive thought, image, or feeling that won't go away, and then engaging in a behavior that takes away the anxiety associated with that obsession. That's not the way it is here. With OCPD, obsessive compulsive personality disorder, it's about control. It's not a person repeatedly touching things 5 times or things like that. It is like everything has to be ordered. Everything has to be exactly as I had it planned. It's a perfectionism is one of the key elements of this. So preoccupied with order and perfection that they lose any flexibility and openness. I've had colleagues with this disorder as well, and it can be kind of a pain because if you put anything out of order, you're reprimanded. You are criticized for not paying any attention to how things are supposed to be in the orderly way they're supposed to be placed. And so it can, when things are out of order, it can create some anxiety for the person, but a person with this disorder is usually very cold, demanding, strict, and will rush to put things back in order. They judge themselves and other people harshly. They're usually inefficient at work because they're so perfectionistic and often considered cold. Other characteristics of this, control is a huge factor here, making everything just so it fits with their plans, their thoughts about the way the world should be. Schedules and rules are all important. Regularly checking for mistakes, so again, not very efficient. They may be so devoted to work. I mean, they maybe look like a hard worker, not going to be very efficient or effective in it, but they feel like they have to devote themselves to that because that's what matters. And they may just not even have a personal life, any personal hobby or sports or music or anything they do at all. Some argue that it's excessive conscientiousness that is the underlying factor in this from the Big Five for personality factor model. Like I said, it's only weakly related to OCD because there's no obsessions or no compulsions. And once again, it's egocentric. People with this disorder don't mind their own tendencies so much. They're very high on assertiveness. So people with this disorder will impose their order on other people. They're not very agreeable. They're not very open. They're not big on pleasure, so rewards don't mean as much to them. And they do want to avoid harm. So avoiding punishment is a piece of this. Some argue that this comes from really harsh toilet training as a child. That would be the psychodynamic perspective. Others, that is a cognitive style that is dichotomous, that things are either perfect or they're catastrophe or disaster. So having that kind of split with no gradations or degrees of in between, that even parents will exaggerate the outcomes of the mistakes or errors. Rarely do people with this disorder seek treatment unless they are depressed or have another anxiety disorder. Yeah, so I think that pretty much captures that. So I'm going to, let's see, take a break here and do another clip just based on cluster B.